Thrilled to see that you're.
This is Dave Holtzman. I'm sorry I don't have my camera working right now, but it's a pleasure to introduce our speaker today, Jill Cigliana. She's going to talk about care ecosystem dementia navigation for improved patient and care partner outcomes. Before Jill starts, I just wanted to give a brief background about her. She's executive director at Memory Care Home Solutions, which is a nonprofit organization in St. Louis, whose mission is to improve dignity and quality of life for people living with dementia and their families by transforming evidence-based interventions into accessible healthcare solutions. Jill oversees an interdisciplinary team of clinicians who deliver non-pharmacological interventions for dementia in the community. She has more than 23 years of experience serving this population in acute, home health, and community-based healthcare settings. She has an MS in occupational therapy from WashU, and she leads the dementia community of practice for the American Occupational Therapy Association and has served as project director of multiple grant-funded projects for the Administration of Community Living's Alzheimer's Disease Program Initiative. So Jill, welcome to the Night ADRC's noon seminar. It'll be great to hear from you.
Thank you, Dr. Holtzman, for that introduction. I'm happy to be here today. I have no disclosures to report, and as Dr. Holtzman mentioned, the work I'll be describing today is funded in part by the Administration for Community Living. And when Dr. Mulder invited me to do this talk, I did not know we'd have breaking news to discuss in the landscape of dementia care and coverage for services. I feel like there's never been a more exciting time to be working in the field of dementia with new blood tests, new drug therapies, new coverage for non-drug services, and much of that great work happening right here in St. Louis. So very exciting times. Today, I'll be describing the evidence base behind our community dementia navigation services, the outcomes for people living with dementia and their care partners, and tie all of this work into the guide model that was just announced last week by the Centers for Medicare and Medicaid Services. And today's talk is really the story of the evolution of a nonprofit organization founded 20 years ago with much support and advice from this very community here today, including Doctors Morris and Carr. Memory Care Home Solutions was created to fill a void in services for families trying to manage the progression of dementia at home. Dr. Holtzman already shared our mission. We achieve the mission by transforming evidence-based interventions into healthcare solutions that patients and families can actually access in their communities, with a vision that this population that we all serve together will have access to an exceptional standard of care. So we provide 4 lines of service outlined here on this slide, and all clients enter Memory Care Home Solutions through dementia navigation, where families are paired with a navigator for monthly meetings on common care priorities and challenges. The evidence base for this program is the care ecosystem model, which was developed at University of California, San Francisco. So this service line for families who participate here locally is funded entirely through grants and donations with no out-of-pocket costs for families. And this is the model we'll be discussing in more depth today. The second line of service, which many of you are also very familiar with, and I've presented on previously for this group, is our occupational therapy program. The OT program is based on COPE, care of persons with dementia in their environments. It was developed by researchers Lori Gitlin and Catherine Pearsall. And we funded this service line through grants, philanthropy, and some reimbursement through Medicare Part B benefits. Our third direct service is individual counseling, which supports the mental health of our family care partners. And this therapy is provided by licensed clinical social workers, and again, covered by grants and some Part B Medicare benefits. Finally, we offer educational workshops for professionals and the community on best practices in dementia care. So the goals of all four of these services are really to improve the health and well-being of people living with dementia, reduce family stress, and delay or prevent hospital and nursing home utilization. And while we do have charitable funds to help cover all of these services, patients may receive a copay or deductible expense for the two of our clinical service lines, which are the OT and counseling. So this slide may look familiar to some of you because last time I presented to this group, I left you with this slide. Last time I was here, I was describing the positive outcomes from our translation of the COPE intervention and sharing the lessons we learned from that project. So we committed to ongoing delivery of our OT service line based on COPE, which we continue to deliver today. And what we learned from that project is that COPE is best suited for families who are already facing significant functional decline and the behavioral and psychological symptoms of dementia. So families who are really seeing the effect on daily life are people who are very motivated to participate in OT services. So we had many families. If you look at the slide, it was 572 just during this data capture period who wanted dementia navigation, but who did not want or weren't ready for intensive in-home occupational therapy services. So we served these 572 families and decided it was time to align our practice more closely with an evidence-based model for dementia navigation. And that's what we're talking about today. As always, we've remained committed to improving sustainability for non-drug dementia interventions by making use of existing billing codes and advocating for payment reform for dementia services. And we don't do this just to make memory care, to increase our own revenue. We do this because we know that here in St. Louis, we rely heavily on philanthropy and it really carries us. But we recognize that there aren't fundraisers like we have at Memory Care Home Solutions everywhere else in the country. So these services are really not possible in most places without payment. And from an equity and accessibility lens, we believe firmly that patients should have access to treatments for the chronic health condition of dementia through their health insurance benefits. And we've really had the honor to meet directly with CMS for over many years to highlight these issues. So this brings me to our current project, which is another grant through the Administration for Community Living, which has allowed us to align our navigation service with a standard evidence-based protocol. So this funding mechanism requires the use of an evidence-based program, and we selected Care Ecosystem, which was developed by Kate Poseen and her team at UCSF's Memory and Aging Center. This funding mechanism also requires grantees to address underserved dementia populations. And the government defines these populations as people with dementia who live alone. We all know there are extra challenges when people are trying to navigate without support. Also, those who are experiencing moderate to severe behavioral symptoms. I like to say that's our sweet spot of service. We have, unfortunately, people aren't often reaching out for help until they're already experiencing some moderate to severe behavioral symptoms because that's what upsets everyone's lives. So we serve a lot of this population. And also people who are living with intellectual and developmental disabilities who experience earlier ages of onset and higher prevalence of dementia disorders. And we work with several IDD partners here in St. Louis and occasionally with Dr. Ansis and some of his work to serve our IDD community. So this is a 3-year project and we're in the second half of year 1. Our direct service goals are to implement care ecosystem in a standardized care delivery system to decrease adverse health events and improve quality of life for people living with dementia, and to boost confidence and well-being for their care partners. We also have some outcomes around our educational activities, such as improving knowledge on best practices in dementia care. So I'd like to highlight our project partners who've leveraged their support for this project. Our biggest partner is here today, which is the Memory Diagnostic Center as our strongest referral partner with whom we share many patients and families. We're deeply appreciative and love collaborating. The SIUE School of Pharmacy is providing consulting pharmacy education and support. ESSA Health is testing a primary care referral pathway for dementia navigation services, which we're excited about because most of our referrals actually come from specialty care providers like the MDC. So always great to see primary care taking an interest. And UMKC is serving as our external evaluators for the project. So happy to see we have some evaluator representation on this call today too. We selected Care Ecosystem as our evidence base because it's most closely aligned to our existing navigation service. So we've been providing navigation and consultation for many years, but this project allows us to align our practice with the standard protocols of Care Ecosystem. This program demonstrates excellent results and is sustainable in that it utilizes unlicensed navigators to extend the reach of the clinical team. It has been tested and proven effective in a telehealth delivery mechanism. That was also important to us because it allows us to reach people who have transportation or other barriers to accessing care, particularly people who are in rural parts of our region. Care Ecosystem has been well studied at UCSF and other health system test sites across the country, and results of randomized controlled trials show improved caregiver well-being and self-efficacy, improved quality of life for people living with dementia, also reduction in ED utilization, prevention of financial exploitation and abuse, and improved medication management. So these are all outcomes we're hoping to see through our work as well. In the original research protocol, which is depicted here in this slide, Care Ecosystem was delivered by care team navigators. So they're in the yellow circle there, paired with a dyad, a patient and a caregiver. And this yellow bubble is supported by a Care Ecosystem clinical team comprised of a pharmacist, a nurse, and social worker. And all of this team works together in coordination of care with established doctors. So care team navigators assess the needs and priorities of each family and then develop a care plan. After that, they meet monthly over the course of a year. So this is a long intervention to work on the care plan and address the topics that you see here, which are the most common concerns among families, such as how to manage behavioral symptoms, how to improve the safety of the home environment, advanced care planning, and something we love to focus on, which is caregiver well-being. So navigators meet weekly with the clinical team and can escalate issues to the clinical team as needed. For the implementation science attendees in this room, this is where we are in our implementation of Care Ecosystem. So we're kind of right here with the yellow star. I will describe some of the minor modifications we've made to the original research protocol. That was step one. We have manualized the program for delivery to fit our organization's staffing model and resources. And something we're very excited about, we've hired an amazing team of navigators with diverse backgrounds in case management, crisis prevention, community organizing, and aging services. And we are currently actively enrolling families in the dementia navigation services based on Care Ecosystem. So this is where we are. And then of course, evaluation will take time. We're continuously collecting data, which we will analyze with the help of UMKC on a semi-annual basis, leading up to a final report in 2025 that I hope I can come back and share our results with you all. This slide describes the core immutable treatment elements of care ecosystem. So as designed in the research protocol, there are navigators who build rapport with dyads and personalize the care. They provide monthly follow-up and support. Care team navigators meet with a weekly, with a multidisciplinary clinical team. And care ecosystem requires that the team continually update and expand a shared database of local resources and vetted educational information. So many of you call us all the time asking about community resources. And I think this is because you appreciate our depth of knowledge in this area. So, you know, dementia navigation alone is not a solution for families. It still takes the village. And so it's very important that we, in this model especially, know our village of community providers, because these families need all of the support and services that they can get. And it's helpful to know in great detail about these resources so we can connect people to the right resources at the right times. Care ecosystem requires telehealth technology and electronic medical records capabilities, which enable remote care delivery and data management. And all care team navigators must complete the official care ecosystem training course and any additional site-specific requirements. Oh, here we are. So this is some of the intervention refinements that we've made at Memory Care Home Solutions. So these are minor modifications. We call our care team navigators simply dementia navigators. That seems to make more sense for the families we serve. We have added occupational therapy as a discipline to our clinical team because we think OT is an essential team member. We didn't naturally have a pharmacist on staff here, so we are consulting with the faculty at SIU. And because we are coordinating care with doctors' offices, which already have physicians and nurses on staff, we decided not to add a nurse to our team, but instead to coordinate that care with families' existing providers. And we have kept the social work role on our clinical team. And because we follow all of our families for a year or longer, we have deep knowledge of the local aging service providers and also of the outcomes of the referrals that we make, including referrals to in-home care or adult day programs, to local area agency on aging programs, and other respite options. And I would say we exceed the training expectation for care ecosystem in that our navigators complete the care ecosystem course, but they also have a minimum of 240 hours of additional training before they ever start to meet with families on their own. So with UMKC as our evaluators, we will be tracking the following outcomes. So we're using to track quality of life for people living with dementia, we're using the DemQual. We will be following healthcare utilization using the LACE index, and we will be using a caregiver self-efficacy scale that was designed as part of the care ecosystem trial. And we do have some other outcomes that we're tracking as far as how our team is doing as interventionists with fidelity to the intervention and confidence in delivering this intervention. And of course, we track knowledge change, pre and post knowledge change when we do educational presentations. So at the top of this talk, I mentioned our commitment to sustainability. And despite our best efforts for years at utilizing existing billing codes, we have found that reimbursement does not begin to cover the costs of delivering this type of care. This work is complex. It involves difficult family dynamics. It involves coordinating schedules with one and often many more family caregivers. So it's been a challenge. But thanks to funding from Missouri Foundation for Health, we've been working with healthcare consultants at BluePath to design a mix of coding options to allow more providers to deliver and also be reimbursed for non-drug dementia care. We have also contributed to a billing guide for dementia services, which is published by the National Alzheimer's and Dementia Resource Center and housed online, open access for anyone. I'm realizing I did not drop the link to that billing guide into my presentation, but as we're talking at the end, I will put it into the chat. And here at Memory Care Home Solutions, we are currently utilizing the OT billing pathway that you see on this slide and the behavioral health billing pathway. We, as a community-based organization, are not currently billing for any care planning and navigation codes because these in green they're in a category of billing codes called evaluation and management codes, and those must be billed through a physician or advanced practice provider, which we at Memory Care Home Solutions do not have on staff. All of this is to show you that billing is complicated and it's very piecemeal and disjointed, which is why we are beyond thrilled with some payment reform developments that have come about recently. So first, there are some proposed changes to the physician fee schedule that for the first time would cover caregiver education and training without the patient present. And this is really important to us in dementia care because I'll give you an example from our occupational therapy service. So one of the most challenging functional problems that we address in occupational therapy is resistance to bathing. So the person living with dementia maybe avoiding hygiene tasks. The family's been encouraging the person to bathe. It's still not happening. And it often becomes a fight for the family because the family's horrified that the person isn't caring for themselves, and the patient is really convinced in their own mind that they are as independent as they've always been, and that they're managing something as personal and central to dignity as bathing. They think they're managing just fine. So you can imagine that so prior to this proposed change, occupational therapists can't bill for OT services unless the patient is present. However, this conversation and the training that is required to accomplish the task of bathing is often a trigger for agitation for the patient. So this change in the physician fee schedule would allow us to have private education and training with the caregiver, and for our therapists to be reimbursed for this work. And then they can educate and train the family very openly and candidly, and then maybe at the next session go back and include the patient and accomplish the bathing routine together as a part of traditional OT self-care training. So this is an exciting development. It's not officially passed yet, but if approved, it will go into effect January 1st. And then even bigger news, late breaking news. I was really excited to be invited to attend the NAPA Advisory Council meeting last Monday in Washington, D.C., where WashU's Dr. Bateman is a member of the council, was there. It was really a thrilling day because the Centers for Medicare and Medicaid announced a new model of care for dementia. This will be a test model. And like you, I just learned about this model last week, so I don't claim to be an expert in all that it offers, but we will all together be learning more. This week there's a webinar. I also had the opportunity to meet with the team at CMMI who has been developing this model. I've been meeting with them over time and spent some additional time with them last week to just inform the build out of this model with stories from the front line, because there really are very few people, in the absence of a payment mechanism, there have been very few people across the country doing this kind of work. So the guide stands for Guiding an Improved Dementia Experience, and it is a package of services to improve quality of life for people with dementia and reduce stress on their caregivers. This model is all very nicely aligned with the requirements in the care ecosystem standard program. So this is just information that CMS has released last week, which is that the outcomes of interest to Medicare are that this comprehensive dementia service would improve quality of life for people who are living with dementia by addressing their behavioral health and functional needs, which is why we love having OTs on our team. We think OTs are particularly beneficial in addressing functional needs. Coordinating care for them, including addressing co-occurring conditions and improving transitions in care. And this really is the first time that Medicare has ever included a informal caregiver benefit covered under billing for and about the patient. So this is truly unlike any other alternative payment model or test model that Medicare has introduced, with a particular outcome on reducing the burden and strain on informal caregivers of people living with dementia. It will also introduce access to paid respite services, also revolutionary and a model covered by Medicare. And they're also tracking outcomes for whether these services prevent or delay long-term nursing home care by allowing people to remain in the community. So you'll see that the model is going to require certain components in the care delivery approach. All of these components, maybe minus one, which would be the respite component, are already a part of the care ecosystem model. So everybody who participates in this test model of care will have to use a standardized set of services. They will be required to have an interdisciplinary care team. The navigators, or the team members who are interfacing with families, must have some extensive training specific to dementia and dementia management. And there must be a person-centered care plan. So this is very exciting to those of us who have been doing this work for decades, because it will change the landscape of dementia care moving forward in our country. So the additional benefit within this service model is that families will have access to a respite benefit of up to $2,500 per family per year, so that caregivers can take a break from caregiving to maintain their own health and well-being. And this will really push our community respite providers. One, it will increase the number of families who are available to take advantage of respite offerings. And I think it will improve the dementia capability of our region, because we will all have to work together to solve the need for respite in creative ways. So some key takeaways from these developments and through our learnings over the past 20 years of developing or providing evidence-informed and evidence-based dementia services, is that really for the first time ever, there is validation at the highest level, the highest policy level, for the contributions of informal care partners. We all know that family members and friends are providing 80% or more of the care for people living with dementia. And this is a first in really recognizing and shining a light on the contributions of those caregivers and taking a first step in addressing their needs as well. The focus of all of this work is exciting in that it brings multidisciplinary teams together, because these, as I've mentioned, these problems are complicated and there are not easy solutions. There aren't easy right and wrong answers to approach how a family goes about managing dementia progression at home. So we're excited that the new payment advances and the new care models proposed really value multidisciplinary contributions and the use of navigators who can extend the capability of clinical staff. You know, we all know there aren't enough neurologists and geriatricians and specialists of any sort to serve the volume of people who are affected by dementia. So by thinking creatively about ways for frontline navigators who by design could be community health workers, and we're excited to include community health workers as we continue to build out our model. I will say that of our current navigators, we don't have an official community health worker because ours come from some different backgrounds, but they are all unlicensed in that they're not licensed clinical social workers or occupational therapists. They bring a different background, but they extend the ability of clinical staff. We're excited that reimbursement is improving for non-drug dementia treatments. It used to be absent, so this is progress. And these changes will expand the dementia capability of all of healthcare and aging service networks. So that's a longer term outcome of these changes, but something that we're really looking forward to, seeing this big macro systemic change, how it affects the dementia capability of our region. And another important takeaway is that community-based organizations like Memory Care Home Solutions are poised to provide dementia care services and bring deep knowledge of the needs of the community and the local resources. So these opportunities really provide all of us with new opportunities for partnership, which was why I'm really happy to be here with you all today, because this is an important community of providers who serve this population. And the work of providing comprehensive wraparound non-drug dementia services is complicated, but we are all here united by the goal of improving health and quality of life for our patients and families. So we'll be on the webinar to learn more about the test model this week. And after that webinar, we look forward to convening stakeholders and partners so that we might get together in the same room and discuss collaborative approaches to test this model of care for the benefit of our region. And, sorry. So next steps for Memory Care Home Solutions is we're already enrolling families in care ecosystem. As I mentioned, we're exploring being a test site for the guide model. We will be, for our ACL project, we're enrolling dyads for our program evaluation through February of 2025, with our final analysis due in October of 2025. And I would like to share special thanks with the UCSF team, especially Sarah Delaney and Kate Poseen for their leadership and support of those of us around the country who are trying to roll out evidence-based programs for dementia navigation. And that's all I have for today. So I'm leaving my contact information with you, also a link to refer clients to Memory Care Home Solutions programs. And Dr. Holtzman, I'm happy to take questions or
Thanks.
discussion.
Thanks very much, John. It looks like you're on with video. Do you want to?
Yes, I wanted to thank you, Jill. It's nice to see you again. I think this may be the third time you've presented at this seminar. I can't, my memory's not too good, so
Of course, your memory is perfect. It is the third time I presented.
and thank you for all the updates, the recognition of unpaid family caregivers and support for them, and the reimbursement issue. And we've always appreciated Memory Care Home Solutions multidisciplinary approach. So I think that's just terrific. And I wanted to congratulate you personally on becoming executive director. And that's a great step forward. And let this group know, and here again, my memory is going to fail me, that Memory Care Home Solutions really began with the daughter of one of our memory and aging project participants, Lisa Barron. Mother, I think, had dementia, and then after she passed away, her father, Richard, was quite a supporter of the Memory and Aging Project also. So there's a lineage there that I think is great. And Lisa really in those early years did just a fabulous job to get this Memory Care Home Solutions established and able to help so many people. So I just wanted to let this group know about that heritage. And my final comment, it's not a question, is Kate Poseen just joined our Night ADRC External Advisory Committee, and hopefully she will be coming in person next year. And if she does, we should let you know so that you might have a chance to interact with her.
That would be fabulous. And thank you very much, Dr. Morris, for acknowledging our founder, Lisa Barron, who did, just by virtue of her own family's experience, and it was her in-laws, her husband, Doogie Barron's parents, Charles and Betty,
I see.
who inspired, and highlighted the need for services that support family caregivers. And it really is the privilege of my career to take over the leadership of the organization upon Lisa's retirement. And she is staying involved in a director emeritus role and continuing policy and advocacy work on behalf of people living with dementia. So the story of the Barron family is the story of Memory Care Home Solutions. And what's amazing about it is that it is such a universal story that no one is prepared, but everyone wants to do the best job they can for the people they love most in the world, and we ought to have access to services and supports to help people get through this. So thank you for that acknowledgement. And I also wanted to say that on the topic of Kate Poseen and the UCSF team, they do a fabulous job. So, we've translated a couple evidence-based interventions now. And the first time we did this with COPE for our OT services, no site in the country had yet implemented COPE. So we were blazing a trail. It was very difficult. We had great support from the researchers who developed the intervention, but it was a lot of hard work. But at UCSF and Kate in particular, they have built a network of people who are implementing, and they get all of us together monthly. So we have other people to share lessons learned, to problem solve and brainstorm. And so that shared learning is a lot of fun. And I feel like it's accelerated our ability to get this model to our community. So they're a great group to work with.
Great. And on a personal note, please give my Congratulations and best wishes to Lisa when you next interact with her.
I sure will. Thank you.
You bet. Dave, I thought I saw a question in the chat from Andre Denny.
There is one. Andre, do you want to unmute?
Sure. And Jill, I was told by one of our colleagues, elsewhere, that they thought that caregivers were going to have an opportunity to be paid somewhat for their role as caregivers. And I noticed you did say in one of your slides, like they may be some kind of recognized as part of the care team. I don't know if this is like information that's still coming and that you're waiting to find out more about this, or if you already have heard, but I'm very interested because I get asked that question a lot by caregivers.
Sure. So there are a couple payment mechanisms now specific to the guide model. I don't know that primary caregivers will be able to be paid, but primary caregivers will have access to $2,500 worth of annual benefit to take a break. So that's phenomenal. But there are other mechanisms within, for example, Missouri Medicaid, home and community-based service waivers, where family caregivers can be paid. But again, and there might be some benefits through the VA. So they're very specifically tied to income and Medicaid eligibility, which is great for people who are eligible for Medicaid, but then it is not available for in-home family caregivers to be paid if the person living with dementia is not a Medicaid beneficiary. So, but there are different benefits through the VA system that provide some payment for family caregivers. So I think that's why it's helpful to have navigators who know these systems of benefits, because it's all very complicated. And if it's hard for you and I to understand, and all we do is help people who are on this journey every single day, then that means it's impossible for families to understand. And and just giving them a list of resources is not helpful, because so many people don't even understand the basics of Medicare and Medicaid to know what benefits they are eligible for. I wish our systems were easier to navigate, but I'm hoping that a payment mechanism like this through Medicare will make those pathways easier. And to be building out a workforce, a frontline workforce of people who know how to navigate benefits and resources will be a tremendous benefit to families. I'm sorry, it's a complicated answer.
It looks like a few other people have questions. Do you want to? It looks like Ellen Binder has a question. I can read it if you don't want to say. Ellen, do you want to unmute?
Can you hear me? Can you hear me?
Yep.
I just wondered, is the funding pending or is it approved? I mean, sometimes they write programs, but the pending isn't there. So I just wondered, is this something we can start using, or are we still waiting for more approvals?
Still waiting. So this will be a test model for 8 years. This is a long journey that is just beginning. So, and nobody can use this new billing model and care model unless they apply to be a test site and enter a specific contract with Medicare. And even then, it will only be for original fee-for-service Medicare beneficiaries, until the Medicare Advantage plans roll out an offering. So even this, while it's historic and transformative development, these changes will not happen overnight. So there's a webinar this week to learn about the application process to become a test site. And then the first year of performance of this test model will begin July 2024. So this leads me to believe that the model is approved by the government and that they can begin testing next year. And they're going to spend the rest of this year and until July contracting with test site providers.
Thank you. Which you will be? Does that mean that all of us who refer to you can participate?
Well, we will apply to be, but there are no there are no guarantees. But what I can guarantee to you is that we as a charitable organization will continue delivering the services that we have always delivered for 20 years. So because we'll do it whether we're paid by Medicare or not, that's what we raise funds to do. Because that's what our mission, that's why we were created and why we exist. So your patients right now are already participating in care ecosystem if they're in our navigation services. So
we can't talk about respite care, those kinds of things. That's the future.
That is the future, and maybe as soon as July of 24.
Okay. Thank you.
Yes.
Presentation. Thank you.
Thank you.
Suzanne, did you want to ask a question?
Sure. Well, I wanted to thank you for that great overview. We refer a lot of our patients to you and they really appreciate your services. I did have one question, and that was sometimes it's hard to find appropriate counseling services for caregivers. And you mentioned that you offer one-on-one counseling.
Mm-hmm.
Can you talk a little bit more about the logistics of that? So how do you assess whether the caregiver needs counseling? Do you use your own counselors or refer them somewhere else? How's it paid for? And if we think we have a caregiver that needs counseling, can we send them to you and you will help with that? Or how would you recommend kind of accessing those services?
That's a great question. And this is sometimes a little confusing, but everybody first starts in our program through navigation, because what we find is that even people call us and all day and think they want a one-off, like, I just want to do counseling, or I just want an OT to come out and do a one-time home safety evaluation. But what we have found is that it's never that these families, it's not truly helping people to just provide the one-off. Like, we want to be partners with them, and the navigation process is how we start with that comprehensive assessment where we're looking at what are the needs of the family, what are the needs of the patient, and how can we meet those needs? What are their immediate priorities? So, and it's from that initial assessment that we will offer people our clinical services, which are occupational therapy or individual counseling. And that's only because we could never fully meet the need. And what it turns out, most people really want and need, like the 500 people we thought who needed OT last time, of the 800, 500 really didn't want OT, even though that's what they were referred for. So if people know they want a counselor, and you can immediately connect them with mental health support, I think that is the right thing to do. If people want a coordinated approach to manage dementia progression at home, send them to us. And we have both. We have our own in-house LCSWs who provide psychotherapy for caregiver mental health. We use a short-term, I'm probably going to say it wrong, brief solution-focused therapy approach. So our therapists don't become the long-term community counselors, but many people don't really want or need that. They need a brief dose of mental health support to learn some coping strategies, to adjust to some anticipatory grief, and to redefine the relationship in the changing dynamics as a person progresses through dementia. So we do both. We provide in-house individual counseling and we refer out to longer term community counseling. again, I feel like I'm giving terribly complicated answers to all of your really good questions, but everybody starts at Memory Care Home Solutions in navigation so we can get a big picture of all of their needs and funnel them to the right resources at the right time.
Thank you. Sounds like you're trying to provide comprehensive care.
We're giving it our best shot. You know, and if who knows, you know, with adequate reimbursement, we could have full teams, you know, and people could access the exact clinician that they'd like, you know, at any given time. But what we're trying to do through navigation is meet the broadest needs of people and then connect them to more intensive services when the time is right.
Great. Well, Jill, thanks very much. Are there any other questions anyone has? Nooper,
Oh,
you're on mute. There you go.
If I could just make a quick comment. So Jill, we last met up at the AFTD Education Conference in May. So thank you so much for being there and being loud and proud and having not just a desk, but offering support kind of in real time for a lot of our participants. So even the full dementia spectrum. And what was recognized by AFTD as we were planning the conference was just the depth of resources that were available in our region, of which Memory Care Home Solutions is a strong pillar. Apparently, when AFTD goes to new host cities for their annual conferences, they'll have a lot of asks and ask do you have this resource and that resource? And they often come back empty-handed. And that wasn't their experience with us. So kudos to Memory Care Home Solutions for very well representing resources in our area. Thanks.
Well, thank you, Dr. Ghoshal. I mean, there's no more exciting. I mean, we are really lucky and really fortunate here to have the Night ADRC, to have the Memory Diagnostic Center, to have other healthcare partners who really care about these issues, to have a very strong Alzheimer's Association chapter. I mean, you know, we really are very fortunate, and this is a great place to do the work. And we here feel lucky every day to know that we can connect people to amazing providers like all of you because of the resources at WashU.
Right. Well, Jill, thanks so much. We really appreciate all you're doing, and hopefully we can continue to work together.
Absolutely. Thank you, Dr. Holtzman, and everyone.
Okay.